So, good morning, friends. We will be starting a series of lecture on ECG. So, this will be the first lecture, and it will be followed by around 20 to 30 lectures. We will complete every aspect of the ECG. Okay. So, first we will understand some basic concepts regarding ECG. So, today we will mainly discuss about the P wave. So, see, the P wave is the first positive deflection on the ECG. So, you are saying this is the P wave. First positive deflection is P wave. This is the P wave, and it represents atrial depolarization, whereas QRS represents ventricular depolarization, and P wave represents atrial depolarization. Its duration, don't remember this duration. As we will go on the lecture, we will try to understand what is the actual duration and what is the normal duration. Okay. Now, some important points regarding P waves are as follows. First thing, that P wave, it has a smooth contour. What is the meaning of a smooth contour? A smooth contour means it is like this. A normal P wave. It is not notched like this, or it is not peaked like this. If this or this is seen, that means it is an abnormal P wave. That will be called as an abnormal P wave. Okay. So a normal P wave has a smooth contour. First thing. Second, a P wave can be biphasic as well as it can be a uniphasic. In that we'll discuss in detail. In lead V1 we see a biphasic P wave, and uniphasically is seen in lead 2. A biphasic P wave is like this, and a uniphasic is like this. Please remember, if you see inverted P wave, it is not a normal P wave. So biphasic P1 in V1 is a normal P wave. Uniphasic in lead 2 is a normal, that is positive deflection is normal. But if you see only inverted P wave, that is not a normal P wave. Third, P wave is erect, always erect in lead 1 and lead 2. If it is not erect, you have to think of some pathology, and it is inverted in lead A, V, R. And the final point, the normal direction of polarization is between 0 to 70 degree. Normal direction of depolarization is between 0 to 70 degree. So these are some important points regarding the P wave. Now, these are some things which are written about P wave, but before understanding these things, we'll understand something like what is biphasic or monophasic. Now, if we talk of lead, first we'll talk of lead 2. Now, I'm drawing this person. These are the two upper limbs, these are the two lower limbs. This is the left side and this is the right side of the person. If we talk of the lead 1, this is the positive electrode, this is the negative electrode, and so this is lead 1 with the net direction downwards. Okay. For lead 2, this is positive electrode, this is the negative electrode, so the net direction for lead 2 is this. Now for the lead 3, this is the positive electrode, this is the negative electrode, and the net direction is like this. So lead 1 direction is like this, lead 2 direction is like this, and lead 3 direction is like this. So this is lead 1, this is lead 2, and this is lead 3. That's why we say that 2 and 3 are the inferior lead, because they look to the heart in the same, from the inferior side. But remember, they are in the same plane. So the direction of lead 2 is this, like this. Now, if you talk of the heart, this is the right heart and this is the left heart. This is the right atrium and this is the left atrium. Left atrium is situated posteriorly when compared to the right atrium. So the direction of depolarization is from right atrium towards the left atrium. It is like this. Now compare it to this lead 2. Now lead 2, the direction of depolation is this, and the direction of depolation of atrium from right atrium to the left atrium is this. So they are in the same direction. That's why it is always monophasic in lead 2. So P wave is always monophasic in lead 2 because the direction of depolarization of the atrium and the lead 2 is in the same, is towards the same, is parallel to each other and in the same direction. That's why they are monophasic. Okay. Now, if I talk of the lead V1, now earlier when we were talking of lead 2, we were in the same plane. Now lead V1 is seeing the heart from the different plane, from the front. That's why it is called as the front lead, precordial lead, or the chest lead. Now this is your right atrium and this is your left atrium. Okay, and V1 is seeing this heart from the front side. So when right atrium, this is getting depolarized, the direction of wave is coming towards V1. Okay, so when V1 is seeing right atrial depolarization, lead is coming towards the V1. That's why it has a positive deflection. It has a positive deflection like this. So right atrial depolarization is seen as a positive deflection in lead V1 because the direction of depolarization is coming towards the V1. But left atrium is situated posteriorly to the right atrium. So when V1's the direction of depolarization is like this. So V1 lead C left atrium, the wave of left atrium depolarization is going away from the V1. Therefore, left atrium depolarization is seen as a negative deflection in lead V1. So, right atrium depolarization is seen as a positive deflection and the left atrium depolarization as a negative deflection. That's why we see a biphasic wave like this. So this is the normal biphasic wave in lead V1. So in lead V1 we see a biphasic wave because this initial portion is the right atrial depolarization because of positive deflection, and this is the left atrial depolarization. Therefore, if we want to understand the morphology of each and every atrium separately, then best lead is lead V1. Now coming to this slide. What the right and the left atrial waveform summate to form the P wave that I have told you. If we say that this is the P wave and we divide it into three parts, then initial 1/3 depolarization is because of the right atrium, the final 1/3 of the depolarization is because of the left atrium, and that is the gray zone, it is the summation of the right atrium and the left atrium depolarization. So the first 1/3 of the P wave correspond to the right atrial activity or the right atrial depolarization. The final 1/3 correspond to the left 1/3 activation or depolarization. The middle 1/3 is a combination of the two. In most lead, now that I have already explained to you, like lead 2, the right and left atrial waveform move in the same direction, forming a monophasic P wave. However, in lead 1, the right and left waveform moves in the opposite direction. The right moves in the same direction, that is towards the lead V1, and the left atrium moves away from the lead V1. This produces a biphasic P wave with the initial positive deflection corresponding to the right atrial activity and the subsequent negative deflection denoting the left atrial activation. This separation of right and left atrial electric forces in lead V1 means that abnormalities affecting each individual atrial waveform can be discerned, that can be obtained in this lead. Elsewhere, the overall shape of the P wave is used to infer the atrial abnormality. So this is the exact line from the Goldberg. You can, if you don't want to read Goldberg, you can also visit the site LIFTL. There they have copied the same line. Okay. Now before coming to this ECG, now we have to understand what is right atrial hypertrophy. Now please remember, we have seen if this is your normal P wave, this is known as the width and this is known as the height or amplitude, AMP, that is amplitude. So height or amplitude is less than or equal, it is less than 2.5 small box, or we can say less than 100 milliseconds, and same is for the width, that is width is less than 2.5 small box or 100 milliseconds. So this is a normal P wave width. Now what happened in right atrial enlargement or right atrial hypertrophy? In right atrial hypertrophy, if this is a normal P wave, it becomes like this. Okay, so the width remains same. If this is the width, it remains same, but the height increases, and height is taken as more than 2.5 small box or 100 millisecond. That is seen in right atrial hypertrophy. And the most common cause of right atrial hypertrophy is pulmonary artery hypertension. Therefore, this P wave is known as P pulmonale. Okay, so once you have understand this concept, coming to that question, if you see this, and whenever you try to figure out P wave, look in the lead 2 or lead V1. Now, if we see lead 2, this is the lead 2. Now I will zoom lead 2 for you. See this. This is the P wave, lead to P wave. Now this is if you see this P wave has, this is one small box, two small box, three small box, plus more than that. That is more than three small box. So whenever so this is one small box, two small box, three small box, and more than that. So that is, it is more than three small box. And what we have read, that whenever the P wave is more than 2.5 small box amplitude, this is the amplitude or height, then we say that it is a right atrial hypertrophy. So this is a case of right atrial hypertrophy, and the most common cause associated with it is a pulmonary artery hypertension. And therefore, what this P wave will be called as? This P wave will be called as P pulmonale. Okay. Now left atrial enlargement. As we have seen right atrial enlargement, similarly that we have seen this, if this is a normal P wave, in cases of left atrial enlargement, the amplitude will remain the same. Amplitude will remain the same, but there will be increase in the width. So width will be more than or equal, more than 2.5 small box or more than 100 millisecond, and there will be a notch present. And this notch may or may not be present. It is not mandatory that this notch is present. And also remember the vice versa. If this condition is not fulfilled, then presence of notch doesn't mean that there is left atrial hypertrophy. So presence of notching may or may not be necessary, but this requirement is necessary for left atrial hypertrophy. A lot of ECG you will see notching without this, without width being normal. So with width being normal. So when the width is normal and notching is present, it doesn't mean left atrial hypertrophy. So width should be more than 2.5 small box for calling left atrial enlargement. Then this notch can be or cannot be present. And since this happens mostly in cases of mitral disease or mitral stenosis, this is known as P mitral. Okay. Now, so please read this. Left atrium enlargement in lead 2. Generally we see lead 2. In left atrial enlargement, left atrial depolarization lasts longer than normal, but its amplitude remains unchanged. This is a very important line. Amplitude doesn't change, it's the width that changes. Therefore, height of the resultant P wave remains within normal limit, but its duration is longer than 120 milliseconds. A notch, that is a broken line that I have told you. near its peak may or may not be present, and this is known as P mitral because mostly it is seen in cases of the mitral stenosis. Now this is a very important question. Now this is a normal P wave. This is a normal P wave. Now try to just pause the video and try to know what are the causes of this P wave, this P wave and this P wave. Now this you have to take as a reference. Its width and its height has to be taken as the reference. Now if you see this P wave, its width is normal. Its width is normal, but its height is increased. If you see this P wave, its height is normal, but its width is increased, and also there is a notching. If you see this P wave, its width is increased, its height is also increased, and there is a notching. And we all are talking in the lead 2. So here the height is increased but width is normal. That means this is an example of right atrial enlargement, or we will call it a P pulmonale. Okay, here width is increased, height is normal. That means it is an example of left atrial enlargement, or it is also called as P mitral. And here height and width both are increased, and there is a notching. That means it is a case of biatrial enlargement. Okay, so this can be seen in cases of the severe mitral valve stenosis. So biatrial enlargement or this ECG condition you can see in cases of the severe mitral stenosis. Now these are the two ECG where what you are seeing inverted P wave. This is inverted P wave, this is inverted P wave, this is inverted P wave. So whenever you are seeing inverted P wave, please remember you have to understand one very important thing, that the origin of this P wave is not from the SA node. Now, normally what happens, that if this is your heart, this is your SA node, this is your AV node, and this is the distance between SA and AV node. So normally the heart rhythm is produced by SA node, but if the rhythm is not produced by the SA node, then you will see a inverted P wave. So whenever you have an inverted P wave, that means that the rhythm is not produced by the SA node. Now you have to differentiate whether this rhythm is produced by AV node or it is produced from atrium, somewhere between the SA or the AV node. So how will you differentiate between these two things, that whether the rhythm is produced from the AV node or it is produced from the atrium, somewhere between the SA node and the AV node? For that you have to see PR interval. Now you can very easily understand, if this P wave will be produced by the AV node, there will be no PR prolongation. PR interval will be very short, and normal PR interval is between 3 to 5 small box. So if PR interval is less than 3 small box, that means this P wave is produced by AV node. So if the PR interval is less than 3 small box, that means it is produced by the AV node. And if the PR interval is normal, that means it is produced somewhere in the atria between the SA node and AV node, but not from the AV node. Now this is an inverted P wave. If you see the PR interval, it is 1, 2, 3 and 3.5. That is normal. So here P wave is inverted and PR interval is normal. That means it is not produced from the AV node. It is somewhere produced above the AV node but not from the SA node. So generally it is produced from the atrium. Okay, so it is present somewhere from the atrium, neither from the SA node or from the AV node. So it is an ectopic atrial rhythm which is originating somewhere between the SA node and the AV node in the atrium. Now here what you see, this is the inverted P wave, this is the inverted P wave, but the duration is around 2 small box. That means this is a nodal activity. This is a junctional rhythm actually. Okay. So how to do so? It is nothing but a junctional rhythm. So it is a junctional rhythm. This is very important. Okay. So this was regarding the P wave. Next lecture will be including the QRS and the T, and slowly in 20 to 25 lectures everything will be completed regarding ECG.